Hi, everyone. Thank you so much for coming. I'm Drew Altman. I really appreciate your coming today. It's great to see you all here. Occasionally, we have special events that Barbara Jordan would really have loved, and she would really, really be happy about this event today and about all of you being here in her room today. I was thinking back that I would most often see Uwe referred to as the Princeton professor or the health economist from Princeton. Those are authoritative and dignified titles, depending, I guess, on your views about Princeton and economists. My mother would have loved it if I had those titles. She would always say to me, "Tell me again what it is you do." But I always saw Uwe playing, those are great titles, but I always saw Uwe playing a much larger, more complex leadership role in our field and in healthcare in our country, a larger role than those titles conveyed. In my life, I've had really the special privilege of being able to work with and get to know a handful of truly great people, people like Nelson Mandela, Barbara Jordan. That's why you're in the Barbara Jordan Conference Center, and also Uwe. They were great in different ways. Mandela, of course, was the greatest, but actually he was a crummy speaker, if you think back to his speeches. So I've actually thought in the lead up today a fair amount about Uwe as a leader. He was more in demand than anyone in our field because he was smarter than any of us, and he was funnier than any of us, and he had better slides than any of us, and we lived and died for the times when he would use our data or our slides in his stuff, and he played on that accent that he refused to lose. And I sort of always suspected that back at home in Princeton with May, he actually had a New Jersey accent. He would say, "Hey, May." But I don't think any of those things really explained to me the special leadership role that he played. I think it was because he was our teacher. He gave us ideas and data and a framework to understand the bigger picture in healthcare that we could see glimmers of, but we just couldn't quite put it all together in our heads. So what Uwe did was he helped us think about healthcare, and he also gave us the humor, to be able to deal with the ugly truths about our healthcare system. He was relentless about uncovering the inequalities in our healthcare system. And he was relentless about that, whether everyone wanted to hear about them that day or they didn't want to hear about them that day. Corporate healthcare loved to have Uwe in as their keynote speaker to tell them that they were wimps about healthcare costs, and they are wimps, by the way, about healthcare costs, or how terrible they were. So, think about it. The Princeton professor who railed against moneyed elites and always looked out for the proletariat. It's amazing. But that was Uwe. What I enjoyed most was when Uwe ran right into the realities of politics in our system, which blocked change, and I enjoyed it because when that happened, when he couldn't figure out the politics, sometimes, not all the time, he would call me his political scientist friend, and he would ask me to explain it to him, which I would do my best to do. And I think in recent years, he became a little more comfortable with the politics. He didn't like it, but he became a little more comfortable with the politics of health. Though for him, it was always about moneyed elites protecting themselves. He never viewed it the way we view it, as kind of the virtues and the design of our political system. At Kaiser, at KFF, we relished the time that we got to spend with him and with May as friends. In the early years when we were building our organization at our board retreats that we would often have, and they would come to our board retreats, Uwe was a revered member of our Kaiser Commission on Medicaid and the uninsured, and I think he loved serving on the KCMU. And so we celebrate Uwe today, we will, or the panel will, talk about what he would have made about the debates we're having today in healthcare. But we're also here today celebrating a book, the new book. How in the world did that book happen? It happened only because of the love and the monumental efforts made by May. May is one of the most courageous, ethical, and brilliant people I've ever known. So I'd like to think that we're also celebrating May today, even though she won't have any of that. Please join me in celebrating May today. And I will tell you something that nobody could know and May doesn't know, which is that that book has already had an amazing impact. So I was driving home from the office in San Francisco last Wednesday, and I got a call from a governor of a prominent state. And he said to me, "Did you know Uwe Reinhardt?" And I said, "Sure, I know Uwe Reinhardt. We're actually having," and I described this event that we're having today. And I will reveal only that it was a he. And he said, "Well, I just read his book. And he said, we should do state rate setting. How do I do it?" And I stammered for about 10 minutes. Now I have to have a meeting. So think about that. A governor not only read the book from cover to cover, you might guess which governor it is now, but actually listened to what Uwe told him to do in the book. And so now just three things for me. One is get the book. And second, remember we have a reception after the panel is done, so we'll all have a chance to spend some time together, and we're looking forward to that. And now, the really big thing, it's my great pleasure to ask May to come up here and say a few words. Thank you.
Hello, everyone. I don't think today I have the benefit of the shillelagh stool, because can you see me? Because at the CMS, they have a shillelagh stool, and then I think she used it, and Gail Walensky used it, and I used it. So thank you so much, everyone, for being here this afternoon. It is really such an honor and such a pleasure for me to be here to share with you some thoughts about Uwe and his book. Priced out, the economic and ethical costs of American healthcare. But first, I'd like to thank the Kaiser Family Foundation for hosting this event. It was a lot of work to put it together. I really very much appreciated Drew and Larry and Rakesh and the staff who did this. And I want to say that I thank you for Uwe too, because Uwe loved KFF. Really, it was like an inseparable bond between them. He always would use the work that Kaiser puts out, and he'll tell everybody else. And I have been doing that also. My last friend was the German ambassador to the U.S., because I saw her and she said, "What is going on with all this health reform stuff?" I said, "Yeah, whatever you want to know, go look up Kaiser website." So it's just a wonderful organization. Now, when Larry graciously offered me a few moments to talk about the book, I thought that there are many, many things that I can talk about. But I think, Drew, you had a good sort of opening for it, and that is, why did he write it? So let's call it the genesis of this book. Now, Uwe and I had been telling him, please write a book about everything. And he says, yeah, I will. But then, so he had long wanted to write such a book on American healthcare for the American public. He wouldn't write it for policy wonks, but for the American public and policy makers, to explain to them, I'll quote him, our national health policy, which is a bundle of confusion and contradictions. And the US health system is so complex and often beyond human comprehension. And so this book, he had in mind to dispel the confusion and ignorance and myth and misinformation about our healthcare system, because these things stand in the way of effective reforms. And he also wanted to lay it out there for Americans about the bizarre quirks in our healthcare system that are just unique to the United States, like who actually pays for healthcare, right? I mean, it's not clear, whereas in other systems it's very clear. And also such things as, from an international perspective, are we getting more and better healthcare? Where do we stand among the community of nations? Now, so why did he decide to write it in 2017? So why now question, right? Because he wrote it between the summer and October of 2017. Because he, as you know, many of you know, he worried about American healthcare for decades, and especially the problem of cost and the uninsured. Thank you, Drew, you spoke of that, the uninsured. He cared a great deal about that. And for this reason, he says, I'll quote him, even 20 years ago, it should have been clear that the collision of two powerful long-term trends in our economy would eventually drive the debate on US health policy to the impasse it reached in 2017. Indeed, some of us had predicted that years ago, because Uwe saw, he had a talk called Sailing into the Perfect Storm. And that is a storm that he felt that was approaching in 2017. But the debate is couched in the jargon of economics and constitutional state federal relations. But really, he wants to make it clear that it's not really about economics and the Constitution at all. Instead, at the heart of the debate is a long simmering argument over this one question on distributive social ethics in this country. And here's the question. To what extent should the better off members of society be made to be their poorer and sick brothers and sisters keepers in healthcare? He asked that question over and over, and many of you would have heard him. So what are those, so I'll tell a little bit these two long-term trends that based on those trends that he had actually a very dire prognosis on the uninsured in the US. So number one, as I mentioned, is a rapid increase in the cost of healthcare, and the second one is the growing inequality in the distribution of income and wealth in America. And over time, I will quote him again, over time these two trends, cost and growing inequality, these two trends have continued to price a growing number of American families out of the high quality or at least luxurious American healthcare that families in the higher strata of the nation's income distribution would like for themselves. We have now reached a pass where bestowing on a low-income American even standard medical procedures such as a coronary bypass or a hip replacement is the financial equivalent of a fully loaded Mercedes-Benz. And you all know about prices of healthcare in America. And Uwe was actually right, because I then, I always check these data to see if they're up to date. So now, Drew, tell me if I'm wrong. The uninsured, we have 30 million. And as these are people who are basically priced out of healthcare because of the high costs. Despite our 18% GDP and over $10,000 per capita spending on healthcare, we have 30 million uninsured. Now, in terms of growth, the CMS growth projection was 5.5% a year between 2018 and 2027. But then if you look at the GDP growth projection by the CBO, it's much slower. It's 1.9% between 2019 and 2027. So you've got healthcare growth at 5.5, you've got GDP growth at 1.9. How does that add up? And then we have the worsening income inequality. Just last December, I came across a report put out by the OECD that says that the United States is the most unequal country in the 25 rich nations in the OECD. If you look at our Gini coefficient, it is now 0.45 in the United States, not a whole lot lower than what's in China. China is 0.465. So now, what is that final push? To say Uwe, it's very hard to pin him down, Uwe, because he's always everywhere. So what is that catalyst? You know that, right? So it was really the 2017 congressional health reform proposals to repeal and replace Obamacare. It was the drama that played out within the Republican Party in 2017. It excited Uwe. So in vintage Uwe style, he wrote in the book, to health policy wonks, this one included himself, the details of health reform proposals are more titillating than Lady Chatterley's lover. So Uwe is quite naughty. But then he got serious and he continued. Although the details of the various ill-fated health reform proposals fiercely debated within the Republican ranks in the summer of 2017 are moot at this point, because by late, October, they were moot. These details convey the general thrust of the debate, and in particular, the ethical vision baked into them. Because Uwe worried about if these plans were passed, the impact on families, on their finances. And I think that is why in the second part of the book, he addresses the ethical questions. Because the situation in 2017, which sadly continues to this day, it raises the ethical question just doesn't go away because it was not resolved. So our health policymakers continue to face this question. And he wanted Americans to understand the different distributive ethics different nations impose on their healthcare systems. We can talk about that in our discussion later, and how the US is different from the majority of rich nations in Europe and Asia in that it has never been able to reach a politically dominant consensus on a distributive ethic for American healthcare. And I think there Uwe is really talking about the lack of the consensus on just, what is the health system for in a country like ours. In all these other countries, solidarity is the ethical principle, but here we don't have that consensus. So now, how people also ask me, how does Uwe's thinking on healthcare fit into his work? I think his thinking was based on and driven powerfully by his background and early childhood experience, because he knew what it meant, what it was like to be poor, because he was poor. If you can imagine this little boy in post-war Germany, they lived in a tool shed, no hot water, no heat, no electricity, no bathrooms. The whole family of the 5 kids and a mother and grandmother, the father was away. And they were hungry very often, okay? So anyway, so Uwe grew up under those circumstances, and he did his homework in the sand because there was no money for paper. So he figured out math equations in the sand. So when he reached the age where he could be drafted, he says, I refuse to salute German generals, and he left Germany. He went to Canada. And there again he worked, because he had $90 in his pocket when he landed. And then he just went to work, and then he saved up enough money to go to college, the cheapest college, because he only had so much money. And I can't tell you how many times that Uwe would say, he would just say, he said that he and his family had health insurance despite poverty, right? And without the health insurance he had, I don't think he would have made it, because he had every infectious disease that a child could contract. And so here's a direct quote from him. He said this on Fresh Air one time. I grew up in a tool shed, and I know how good it was when we were paupers. My family, we had health insurance like everyone else in Germany. I've never forgotten that. And I would like American people to have what I had and my mother had as a kid. So that is why I care. Those were his own words. So Uwe's passionate belief that everyone should have health care, that health care based on need and not based on ability to pay, which is the case in our country now, that was the fundamental driving force behind all his thinking, his work, and his advice to anyone who would listen. Because, I mean, Uwe cared about social justice. But I'm going to end now, but I think there are two other things about Uwe that are also important in his thinking and work. And one is that, because he's so fair-minded, that he's completely nonpartisan or bipartisan, however you want to call it. So then he was therefore, I believe, trusted by representatives from both sides and the public. And the other thing is that I think he was a really well-trained economist first of all, not just health policy person or health economist, but an economist with a heart, because he went to Yale. He had a wonderful professor, James Tobin. You probably heard of him. Jim Tobin was a Nobel laureate and was President Kennedy's economic advisor. And Tobin always said, economics should be used to make society better, kinder and gentler. So there's a higher purpose to just pushing equations. And and also at Yale, Uwe, his PhD thesis was actually one of the first pieces of work that used real data to come up, real data plus rigorous economic analysis to come out at policy conclusions and recommendations. So it's data-driven, evidence-based stuff that he did, and that makes it believable and useful. So that's it. Thank you so much.
Well, thanks for that, May. I'm Larry Levitt from the Kaiser Family Foundation, and we have an incredible panel of experts here who we're going to take advantage of to talk about some current health policy issues, but also talk about what I think of as WWUT. What would Uwe think about what's going on today? Certainly joined first by Uwe's longtime collaborator in life and work, May, who you've heard from. Catherine Rampell from the Washington Post, who also keeps me company on my ride home on Marketplace Radio. And then 2 former federal officials and longtime health policy experts, Mark McClellan and Judy Fader. So I want to start. I mean, you heard May and Drew talk about Uwe's work both as an economist, and we certainly knew him as an engaging speaker, and certainly the funniest person in health policy, no question about that. But I think the important thing about Uwe is he also had a very precise moral compass, both in his work and his life. And I mean, if you look at his book, it's not just the economic costs of American healthcare, but the ethical costs as well. So I'm going to start with that as we head into this election. I'm tempted to ask you what might titillate Uwe about this election, but I don't know where that would go, so I'm not going to do that.
I don't think we can beat Lady Chatterley's lover.
No. But I want to start with the ethics. I mean, what do you see as the kind of ethical or moral imperative? What issue poses the greatest ethical challenge heading into this election? And Judy, I'm going to start with you.
Sure. I think that it is the issue that preoccupied Uwe and that May emphasized, which is the distributive justice or lack thereof in healthcare. And coverage and costs are very much intertwined, as you indicated in talking about the intersection of the 2 trends. So I would say that affordable access to healthcare has long been an ethical issue and remains so. We, I would argue, made some headway on that issue in enactment of the Affordable Care Act. As a political scientist, I'm surprised that it's still such an incredible battle. And as we speak, the court is making judgments on its current constitutionality. So the progress we've made is at risk and has been undermined, and was, I would argue, only a step in terms of addressing that issue. So I think it remains very much with us today and into the next election.
Mark?
So before I answer the question, I have to take a couple of minutes to say, I'm going to answer the question, but I'm going to just use this moment to thank May again and just remind everyone just how important and towering a figure Uwe Reinhardt was. I first met him and May at the very beginning of my career. It was like, 30 years ago. I was still a grad student, and from that time on, not only did I get good regular advice, but Uwe and May would have me over for dinner. We'd meet at conferences, and he'd take time to really pick apart the ideas and the issues that I was working on. This was just for a graduate student, not for CMS administrator or something like that. And that kind of heart, I think, as you said, an economist with a heart, was one of his most distinguishing characteristics. He's been a model for me throughout my career, and I still get regular advice from May, but boy, I sure miss him a lot. So on getting to the question, I certainly agree with the affordability of healthcare being a big issue, but the things that I talked with him about most in recent years was I think we're getting kind of in this country beyond healthcare itself being the path to addressing what I see as one of the most core ethical challenges and economic challenges in this country, and that is the trends that we're seeing in the health of our population. So you all know the statistics. We've had 3 years in a row of rising population mortality rates. It's not rising across the board. It's rising particularly for low to moderate income individuals, particularly for people in rural areas. This is completely unprecedented in the United States. It's been seen maybe in a couple of other developed countries like Russia after Glasnost and Venezuela after complete economic disaster. And if you think about the impact of these trends in health on lives, millions of lives, and on well-being, I'd put that up there at the top. And my worry is that we're not at a point where just focusing on healthcare or tweaking healthcare by itself is going to solve the problem. I think part of the reason we're here is because of trends in healthcare costs, But if you look at the underlying causes of these problems, it's things that have deservedly gotten a lot of attention. The great increase in opioid-related deaths, substance abuse disorder, violent deaths, deaths of despair in these populations. The biggest trend is actually in cardiovascular disease. This country saw for 40 years, between 1970 and 2010, this amazing, unprecedented, historic reduction of something like 60% plus, 60 to 80% in population mortality rates from the number one cause of death. It's still the number one cause of death, just now those trends have leveled off and are reversing in exactly those same population groups. And I think what we're learning about healthcare now is that while it can make a huge difference in the lives of many individuals, there are a lot of other things that also contribute to health. And with especially at the federal level, the increases that we've seen in healthcare spending, it's really kind of squeezed down a lot of the other factors that make a big difference in distributional equity in terms of inter-income level mobility, in terms of having a life that's better than the parents that came before you, things like early childhood education, and infrastructure in your neighborhood, safe housing, job retraining programs, things that make the future better than the past. And all of those have really been squeezed in this country. Some of the most promising healthcare reforms that I've been seeing and that we're involved with in North Carolina around the country are trying to get those two topics merged back together, make healthcare really be about improving health, even if that means not only spending more on primary care and prevention, but also on air conditioning or housing modifications, if that's what it really takes, or early childhood education. And I think that is what it's going to take to reverse what I see as a really disturbing ethical trend.
Catherine?
So I remember that one of the last conversations that I had with Uwe, and you were there as well, May, in person, he was putting forth this thesis that we like to think that all men are created equal, but in the United States, that's not the case. I think he subsequently wrote something with that, sort of critiquing the conventional wisdom about that thesis. So I think that's the broader theme right now, is that are all men and women, babies, created equal in this country, or do we start out on very different playing fields, essentially, because of our mother's health while we're in utero, because of our family's resources, et cetera, and our access to health care once we are actually born. So I think that's sort of the broader thematic question and an ethical challenge for us right now. I would say as in terms of a specific policy issue that I have become more interested in, it relates to two subjects that both of you have brought up, which is about distributional impact and access to healthcare, and also rural issues. That what do we do about lots of Americans who are, in many cases, poor or near poor, who are in parts of the country that have less and less access to actual healthcare facilities because hospitals are closing, because doctors are moving away. And this really does bring up the question, are we our brother's keeper? What if our brother is somewhere very remote? And what do we do to try to help those people? You see stories all the time about, a pop-up clinic opens up in an area and people come and from many hundreds of miles away, they drive for days and then they wait in line starting at the crack of dawn or at midnight, hoping to see a nurse or a dentist or a dental assistant or a physician, and trying to get their issues taken care of. And I think we haven't really reckoned with what do we do about these populations, particularly in states that have not expanded Medicaid.
I would say that Uwe would have agreed, and I too, with everything everyone has said here. But I think to Uwe, it's very hard to say what is more important, but one of the most important is still universal health coverage. People need to have access to the health care that they need. But somehow I think, if everybody here can figure out how we can help our policymakers to maybe just to think I mean, the way we're approaching healthcare, is this really the right way? Because if you look at every other country, they would first say among themselves and to the country, so what is our principle? Usually it's equity and access. And then, so they decided already that everyone should have health care, and then they build a system around that. And so everyone does have health care. Now, why is that important? Because because health care at critical moments, it does have tremendous impact on health, because the worst outcome of lack of health insurance is death, right? I mean, we all have heard stories of people showing up in San Francisco General. You were there, it was one of your board meetings. We went to and Governor Newsom, he was the mayor then, he spoke there. And the speaker said, sometimes these people will walk into our hospital and they just die, regardless of what we do for them, because it's too late by then. So you have to have health insurance to save lives, and then health insurance should also then address the social care part of it, the social determinants aspects of it, because you talk about you take a pregnant mother, no prenatal care, and that directly affects the child's future, because there's a whole theory about how the epigenetics affects the woman's egg, and then the woman, once pregnant, in the absence of optimal intrauterine experience, are at risk to develop cardiovascular disease. I mean, the scientific evidence is all there. We know that. So we can see the lack of health care from lack of health insurance, the cost on population health. And all other countries nowadays are just putting a whole lot of emphasis on social determinants. And I think that Uwe would very much care about that too.
So we've been talking about these the kind of ethical components of Uwe's thinking. There's the economic component as well, and his book is called Priced Out. So healthcare prices seems like a good place to start. And I think many people will remember Uwe's article with Jerry Anderson. It's The Price is Stupid, which is still the case. I mean, America spends twice on average per person on healthcare, and it's not because we use more healthcare, it's because we pay higher prices. So Judy and Mark, let me come back to you. I mean, it's a fact that our prices are high, higher than the rest of the world. What's that? No, I don't want you to argue that, but what should we do about it? What should we do about it?
Prices are.
I'm sorry.
What should we do about it?
Yeah.
You can go first.
Well, there's two things. So just to have for the sake of a little bit of argument, I again had a lot of time to discuss these issues with Uwe. There are some differences between, say, a day in the hospital here and a day in the hospital in England or other countries where there's not so much emphasis as there is in the United States on getting a lot of volume through. So we have because of DRGs and things like that, hospital stays are very intensive. There are a lot of procedures that have moved out of the hospital. They're done much more intensively outside the hospital in the U.S. and other countries. But that's not that's not the only or the main thing that's going on. The question in terms of what to do about it is one possibility is we're having this debate in North Carolina right now. The state treasurer wants to impose Medicare prices across the board, or some reference based on Medicare prices across the board for all of the employees in the state, and he's getting a lot of pushback on that. Not just from Republicans whom you might expect to be opposed to price regulation, but also from a lot of Democrats who are very involved in some of the other healthcare reforms going on in North Carolina right now, which are much more about trying to shift the money from hospital stays and more intensive treatments that are high price in the U.S., but that are really accounting for a much larger share of our spending than, say, primary care and other services. And I think we've got a bit of a debate going on about, as with most things in the country, about what's the best way to get costs under control. Is it to take our very much hospital intensive procedure heavy system that's a reflection of high prices on that end of the spectrum and try to squeeze all those prices down and hope for the best? If we control total costs, somehow care is going to transform itself. Or do we want to do something that's more directly about trying to shift the resources out of the hospitals and into primary care? So the University of North Carolina recently, as a counterproposal, said, look, if your goal is getting total cost of care down per person, we'll commit to that. Give us a reasonable goal. Zero real growth? Fine, we'll even do that. But just let us move the money around more. So get away from a kind of rigid price structure like in Medicare. And I have to say, I'm leaning more towards that approach. I think we're way underspending on things like primary care, prevention, targeted social services and human services that could have a big impact on a cost, especially for young people and people with multiple chronic conditions, people with substance abuse and so forth. I don't see just a bit more price regulation solving those problems in the same way as I see around our state and around the country organizations that are redirecting the way that care is delivered, which requires doing more than just squeezing down the prices across the board a bit.
So let me be clear from the outset, I'm certainly, if I would focus as I would on price regulation, it wouldn't be a bit more regulation. So exactly. And on your initial point, or I'm not going to dispute differences in the nature of hospital stays, and we know how short ours are relative to other countries. But I believe that Uwe has in the book the table of a comparison of prices for various procedures, and anything you look at, I think that the price is stupid it just pops out at you as dramatic and is a fact, as you said, Larry. And my way of channeling Uwe is, and I wish I could do it in his accent or some other sympathetic accent, but I'm stuck with mine. I grew up in Florida. You may think I'm a New Yorker, but I grew up in Florida. I think that I believe I have heard him say, although I don't think it's unique to him, that one party's spending is another party's income. And I believe that he felt quite strongly about and May is nodding. I expect you to keep me honest, May. Uwe felt quite strongly about the income protection behavior of the professions, and he tells a marvelous incident in the book that I can't recount, maybe somebody else can, but I won't do it justice, in which he really takes the medical association on the income protection. So I believe that what is particular to the American healthcare system, and I actually do think there is a distributive justice principle. I just think it's lousy, that it is to a great extent, individuals on their own. I think that it is to the underlying problem of social determinants of health has a great deal to do with income inequality, which I was thinking about as we emphasized the issues. And I think that the American system, given the way it has evolved, differs from other countries in lacking a collective government responsibility, not simply for the distribution of healthcare, but for the prices, the cost of healthcare. And what we are increasingly aware of is, as particularly, I would say, exacerbated by the concentration of hospital ownership, is that we have to have a public presence to compete concentrated power in the healthcare industry to have prices be reasonable. I am not in any way disagreeing with any of the other problems we face, but I would say for my whole career, pretty much all of which I knew Uwe, that concerns about other factors affecting health, and there's no question. I feel as though people rediscovered poverty. That has always been an issue, and I would like to see see us address the inequality of income distribution, which is growing dramatically worse. But I would not separate that issue, or you have seen it be a substitute for addressing the affordability of health care. And I think they are separable and distinct issues. And on prices, we need a stronger government role.
So, May, we were talking about this earlier. I remember hearing Uwe describe many years ago an idea for price transparency, where hospitals would have to all bill on the same basis, all bill based on Medicare, and physicians for that matter, bill based on Medicare payment structure. But could declare their own multiplier. So a hospital could say, I charge 150% of Medicare rates. Another hospital could say, I charge 200% of Medicare rates. That would be, I suppose a hospital could say they bill at Medicare rates, but I don't think we would expect any hospital to actually say they would do that. But that would allow consumers, patients, to easily compare the prices at different hospitals, because all the hospitals were billing on the same basis and were declaring what their price levels were. The president just recently issued an executive order calling for greater price transparency. What do you think? What do you think Uwe would have thought about the idea of greater transparency? Is that something that would actually make a difference?
Yeah.
Does it depend how we did it?
It would, and it should make a difference. And Uwe, in fact, has predicted that it's coming. At least over 10, 15 years ago, he says, well, it's coming. He calls the barbarians at the gate. So somebody's going to knock your door down, say, come on, be transparent. Yeah. In fact, that is his formula. He calls it conversion factor. You take Medicare prices, and then if I'm hospital in New York, you are in Washington, Florida, North Carolina, you charge different prices. So then you put it out there. So I am 1.8% of Medicare prices. New York, you're 3.5%. I mean, 3 times, not percent. Yeah, right? So then people will say, if the base is 1, if anybody is over 1, then it's easy for you to figure out, right? So in fact, I'm just working to write such a paper right now. Okay. On price transparency, but then I think that if I can just have a word on the other question about the high prices of U.S. healthcare and what can be done about that, I think Uwe would tell you that the most immediate thing that we can all try to help to get done is to move the United States system to an all-payer system, which means that hospitals gets paid the same fees by all the in other words, all the payers agree on a payment fee schedule, and then that this fee schedule then would apply to all the providers in a geographic location. And this is in fact what Germany does, and Switzerland does it, and the Netherlands does it. So there, there's only one fee. Okay, everybody gets paid the same, but they agree. The providers and the payers agree ahead of time. They negotiate, so then everybody abide that one single fee schedule. And if we could get that done, or even make progress towards it, what this will do is that it will reduce, or ultimately, hopefully, eliminate price discrimination that is so rampant in this country now. I mean, right? Price discrimination in Indiana, some providers were charging like 3 or 5 times what Medicare pays, and that wouldn't happen if this were to happen. Now, fundamentally, if you want to solve the cost issue, of course, the ultimate solution is a single-payer system. You can read about. Because I've written quite a bit about the single-payer system of Taiwan. You can look up, and how they control cost. At 6.1% of GDP, they cover everybody and cover everything. Okay. In fact, there's an article that I wrote as a follow-up of that piece that Jerry Anderson put out. It's still the prices. I compare prices of healthcare in the U.S. with a single-payer system like Taiwan, and then I gave you OECD data to see what prices there are. The OECD countries all have all-payer systems. So you will see that in terms of spending, so here's the spending, and here's a little Taiwan, because they spend so low, and the OECD are next rung up, but they're all about this level, and the US, guess what? It's way over here, right? And you cannot give one price for US. There's the average price, 25th percentile, and 95th percentile. So it's crazy. See, we know what to do, but it's really to get through the political hurdle.
So, May brought up single payer. So I want to start with a show of hands. Who would eliminate private insurance? In the, Catherine,
we're not running right now.
Catherine, do you? So obviously that question dominated the healthcare discussion in the last debates. Do you think that was the right question? If you were up there, what questions would you ask on healthcare?
I think it's it's sort of a facile question, right? The issue is that if you were creating a healthcare system from scratch, probably, well, I don't know, you probably wouldn't have at least our current private insurance system. You might still have private insurance in some fashion. You might get rid of private insurance, right? If you were building everything from scratch. Although Uwe in his book talks a little bit about how he thinks even if you were creating, or he doesn't say in quite this way, but even if you were trying to create a single payer system in this country, it probably would not replicate the success of that in Taiwan, which Uwe and May actually helped design the system there. May was sort of left that part unsaid. But in any case, his argument was, and you can correct me if I'm wrong, essentially that there's too much regulatory capture here, that if the doctors are setting the prices, if the hospitals are setting the prices, they're going to set prices still very high. If they're telling Medicare, which is now Medicare-for-all, how to compensate the various providers. But I think the question right now in terms of what politicians should be talking about is a difficult one, because the kinds of fixes that we need are probably more technical and too in the weeds to capture in like a bumper sticker, right? It's single payer, Medicare-for-all, that's a very easy bumper stickerable slogan. But in terms of actually things like price controls, let's say, whether we're talking about merged hospitals, and that was something that wasn't brought up between the two of you, but there have been experiments with price controls as a means of dealing with the market power that hospital systems have. Or if we're talking about price controls in other settings, that's not something that I think is easily digestible or easily explicable in a debate setting. So I don't know exactly what the right question is. I think it's maybe just saying, or the right answer from a politician would be at this point. It may be just saying, look, I'm going to get the smartest people together in a room. I'm going to talk to the experts, and we're going to design something that will help figure out how to reduce costs, how to improve access, and how to improve insured rates. But again, that may not have the political resonance that it needs. That's why you got to read white papers and op-ed columns, right? Rather than rely on bumper stickers.
President Bill Clinton did bring 500 people in a room, and
Can
I say something about that?
Sure.
It is true that Uwe recommended the single-payer system to Taiwan, and they adopted it, and really made it a beautiful thing, system. But he said, Medicare-for-all in this country, I won't mince words, but these are Uwe's words. It will be, it's a good idea, but it will be an idea that will be dead on arrival in this country. And I think we see the pushback. I mean, the Kaiser polls have shown consistently that if you just ask people, are you in favor of a single-payer system, the majority will say yes. But the yes, you lose many of the yeses once you say, but if it means you can no longer have private insurance, then the response drops, right?
But that's a slightly
And
different
then-
critique from the one that he offers in the book about why single payer is not the solution here.
Right, but I'm just talking about the political realities in this country, right? And sure, why it will not succeed in this country? Because fundamentally, he'll say, because our supply side, the providers, is too powerful, okay? And we have a political system that allows for campaign contributions. And to put it in, again, very, very blunt words, you can buy legislators piecemeal. And so the cat is out of the bag, so to speak, that they're just too powerful, and they won't have it.
So May, both you and Catherine brought up this idea of regulatory capture. Mark, I mean, you ran two big agencies.
I was a capturer, I guess.
I mean, how? I mean, if we had
Uwe has a solution for that too. Yeah.
Yeah. Well, just to maybe to the point of, again, I had these discussions with Uwe too, and why I think he's the best political economist is because he got the economics right, but he also had a good appreciation for the art of the feasible. And I wonder here, I get the point about bumper stickers, but maybe just a little bit more discussion, whether it's possible to ask about in the debates, or maybe it's in other contexts, maybe it's in a column or something. Is about what do people mean when they say Medicare for all or single payer in this country? Look at Medicare today. It's 36% actual people who have enrolled in private insurance plans to get their Medicare benefits. Now they're regulated by me. I actually started that program, the Medicare Advantage program, where they have to meet some performance measures. Their payments depend a lot on how sick their beneficiaries are, but it's proven to be a pretty popular and growing program that's delivered privately with public supervision. In the traditional Medicare program today, for the remaining people, close to half the payments are not according to your fee schedules that you'd like to expand to everybody, but are according to things like primary care medical home payments and bundled payments for whole episodes of specialized care, and payments to healthcare organizations where they get rewarded they make more income when the overall cost of care go down, not up, while they're meeting quality standards. And in Medicaid, that other famous public program that a lot of people like to hate, it's almost all delivered through private insurance plans today, subject to oversight. And I think part of the reason for that growth is that we're finding that there may be some ways to perhaps to have your cake and eat it too. As long as providers make more money when they get paid more for doing more and more intensive services, we're going to keep having these battles where the fights will be between which specialty society has the most political clout and can have the most lobbying impact on getting their rates up relative to, say, not to pick on anybody in particular, but the primary care docs. We tried really hard to re-equilibrate those rates, and I know subsequent CMS administrators have too. It's very hard. On the other hand, if the providers are making more money when they're doing what they actually, I think, really truly care about. They're not mostly there because they want to make money. They're mostly there because they want to help people, and they make more money when they prevent complications and they keep people out of the hospital. I think that's a better possibility. And I think we may not be that far away from getting these kinds of points into a real debate about the future of healthcare in the United States.
I think if you look at the polling, part of the reason why there is this disconnect between how favorable respondents are about Medicare for all and how unfavorable they are when you ask them about, well, what if it meant your taxes are going to go up, or we get rid of private insurance, or et cetera, is that I don't think that people are as married to a particular system as some of the advocates on either side think that they are.
Yeah, they want better health and lower costs.
Right. And how you get there. There are a lot of different paths that can lead to those outcomes. And a lot of them are they're very technical to get to that outcome.
I would take it in a different direction. And Mark, when you said that you wanted to ask them what they really mean when they say that, I don't disagree for a minute that the label applies to a lot of things and is not precise, and there's a lot of
private insurance and not regulated fee-for-service prices.
But when people say Medicare for all, I do not think that is for the most part what they mean. I think that the debate and the discussion that is ongoing is the kind of discussion that Uwe would have encouraged, and it is a discussion about values. And I think that that a lot of what people are trying, who advocate Medicare for all, are trying to convey, and we know a lot, so we know it's imprecise, but I would say that they are trying with a bumper sticker to convey that there is a program, and it is complicated and has lots of issues. I'm not saying Medicare is by any means perfect, but it's a program that people love, that 2/3 of it is government run, that it is perceived as a public health insurance program, and people get it regardless of income, that they get Part A automatically. There it is, you do have to pay for Part B, it's complicated, but I think that the overall picture is that it is a universal social insurance program that everybody gets regardless of income. And that what they're conveying is a value judgment, that people in this country ought to have health insurance, and that Medicare needs work to live up to the values that they are espousing. I totally agree with. But I think that the value statement is something that we ought to be focusing on, and I believe me, I understand all the political challenges, but I think that it raises a question that you raised, May, about what kind of a healthcare system do we want. I think that that's what the debate is raising.
I think what do you all think an interim measure would be to resurrect or to reintroduce, bring the public option back?
Sure.
Mm-hmm. Yeah, I mean,
is that a good bumper speaker public option?
Well, there are a number of bills sitting in Congress right now that do some version of that.
I actually have an op-ed coming out. I don't know exactly when, but it's coming out.
Well, whether
and what is it? What was it? Did you have a title on it, or? Oh.
I don't know what they're going to put it, but it's about public option.
It's the public option, Steve. Whether or not that is the explicit policy, if you look at the last 20 years, that's been the sort of the practical policy. I mean, it's the public programs that have been steadily increasing on both the Medicaid side and the Medicare side through even inactions in very red states. And so, once again, I think I'm back to, if we get past just the bumper stickers and towards what people really want, which I agree is access to care when they need it at an affordable cost, but I'm not sure that we're really focusing on the best way to do that. North Carolina is a purple state. Hate to keep going back to, I just came up from there this morning and meetings on this topic. Got a Democratic governor, a Republican legislature that got a Medicaid waiver approved that really redirects a lot of money and resources into addressing some of these underlying issues. That you talk to some of our Medicaid beneficiaries, they're exactly like May was saying. These are women who, sometimes they don't have homes. Often they don't have support for the nutrition that their kids needs, and they're worried about where's that? Can I get my kid into a pre-K program? How can I possibly afford it? And if you're in situations like that, you're not going to focus on adhering to your diabetes meds, even if they're free. So
I don't disagree with your.
I would just put these together. So my point is that we're having more progress in reform in North Carolina by combining a focus on how do we make healthcare affordable for more, with a focus on how do we change the way that healthcare really
I think
works.
Reallocating resources, I hear what you're saying, but I think that there's an accountability issue here. And I think that you are correct to point out the important role of private entities in both Medicare and Medicaid.
And growing importance by people's own choices, right?
Well, I was saving this one, but I think you did a remarkable job when you put the Medicare Advantage and the drug benefit into effect, but you overpaid by virtue of Congress the hell out of the Medicare Advantage plans. So there's plenty of money to redistribute.
But the Obama administration fixed that.
Let's just be clear on that.
Didn't get rid of the program, just fixed it over.
But I think there is a question as if we are to rely on, to the extent we rely on entities and providers, there's a big a big issue as to how we hold them accountable. And it doesn't work in every state with Medicaid, but there is a regulatory system in Medicaid managed care plans that is not necessarily so prevalent in other arrangements. And and all the pricing concerns that we have are built into the payments for accountable care organizations and medical homes. And so the price distortion that we have in the Medicare program is really quite profound, and to ignore it and simply what disturbs me is to count on the goodwill of organizations, particularly if we move them toward capitated arrangements where they profit more the less they spend. That, to me, is not a very effective way of improving the allocation of resources in the healthcare system.
But with some guardrails, like the way almost every state is doing their Medicaid
You got
program
some
today.
guardrails, man. I'm talking about serious guardrails, and I don't believe I have too much evidence from various aspects of the healthcare system from that capitation. It is not necessarily, it may look like an incentive to be more efficient. It is an incentive to spend less. An incentive to spend less is not good enough as an alternative to deliver too much.
And just to be clear, I'm not advocating for pure capitation of anything. I was just pointing out that is Medicaid today. It's overwhelmingly by state choice capitated.
Yeah, I heard
system.
you, but it's got a fair amount of regulation in it, and in fact, in both Medicaid and Medicare, the prices for providers are set by the state. So Medicare Advantage does not set its own prices; they rely on Medicare prices.
So just to tease this out a little bit, I mean, there's
I have a question for Judy.
Okay.
You know, you say that the capitated system is not the answer, but I mean, based on what evidence? Because Kaiser Permanente is a very fine capitated system. It is, integrated financing, integrated delivery, and as far as I know, that there's studies, a lot of studies that look at the Kaiser population as a whole. They can manage the population health, the Kaiser population health, like their hypertension control. The outcomes are just better. So
I would not. I'm not going to. I'm not up to date on the performance of all Kaiser. I do believe that it certainly had that reputation for many years and may still excel. And I'm not going to say that every capitated plan is a self-interested plan,
right.
A profit maximizing arrangement, but I believe that Kaiser too has responded to some of the economic incentives of the marketplace in ways that are not necessarily conducive to people's health. And to say that there is a good example of behavior under capitation is not to say that when capitation is broadly applied, that the negative will outweigh the positive. And we see it in prospective payment systems. We see the rapidity of responses of providers to a change in their incentives. So when they are rewarded for doing less, there is tremendous evidence that they do less, they avoid patients who are sicker, and that they are powerfully motivated by profit incentives. And so I am guardrail. To go in that direction, I do not do that with equanimity. And I think to the extent that we move the system in that direction, we have to continue to pay a considerable attention, again, to the prices that are paid. In all these systems, the problem is more about price than it is about use, although we can use resources better. But what we need, and I go back to the conversation about raising I think the single payer issue raises the role of government issue, that we need the solidarity, a collective responsibility. It is the role of government to assure that everybody has affordable access to health care. And I am concerned about relying on these guardrails given everything else that we know about self-interest and politics.
Yeah, but you see, if you had a public option
I don't disagree with you.
for people under 65, you just open it up so that allow this public option to compete with the private plans. You don't do away with the private plans. Let them compete. Let the market play. Right? You are not capitating anything. You are not kicking out the private health insurance. Let them compete.
I'm fine, May.
This is actually what Uwe and I we recommended to Senator Sanders back in 2017.
I don't think he listened to you.
No, but I think please try bring it back.
I think that's a good place to leave this discussion. I want to open it up actually to audience questions as well. And there should be roving microphones. Start over here.
Gary Filerman, former. I want to make two points about Uwe as educator, which I feel has been somewhat overlooked so far in this discussion. At the memorial service in Princeton, the dean made the point that Uwe taught economics as an ethical discipline. In that respect, he was a role model to the rest of the economics education profession, if you want to call it that, still teaching economics from the standpoint of Friedman, and still turning out generations of future managers who believe that economics is a value-free art, while in fact practicing it from the standpoint of a particular value perspective, Mr. Friedman's. Point one. Point two, generations of undergraduates have come out of his Princeton courses with that insight, with that concept of economics as a value-laden practice. I think they are very small in number, but across the land making the kind of contribution that he would want them to make.
Thank you. Well, I think we have
Thank
certainly
you.
a student up here who may have come away with that as well.
Thank you so much for bringing that out, because I think in the very, very end, Milton Friedman came around to the thought that economics is not value-free, should not be.
Took him a very long time.
And I will stand up for, as someone who went to Princeton, I will stand up for the other professors in the department who I do not think were necessarily of the school that you are ascribing to them. While I do think Uwe was specifically emphasizing the ethics and morality of economics, I wouldn't necessarily paint a portrait of everybody else as having completely abandoned them. And maybe that was Uwe's influence. I don't know.
Yeah, I think it's actually growing. I mean, being teaching in that profession now. Actually, I should probably ask a couple of my students who are here, but it is possible to get to. It's definitely possible to teach this way. Uwe was a great illustrator of it. I think there are a lot of people around the country who are now instilling that in more of their students. Maybe more need to come, but we're trying. And absolutely, I think the combination is just really powerful for those of you who are still learning or want to learn more about health policy. You can get a lot more done with an understanding of economics and your heart in the right place than you can, with due respect, just with your heart in the right place. So would encourage everyone to pay attention to Uwe's approach. Yeah.
Over here.
Thank you. I'm Alan Lyles. The question I have for you is that there seems to be a mechanism, so I'm offering a lemma to your theorems that you're asserting, and that is the Independent Payment Advisory Board. The IPAB, as I recall, was never repealed, that it was zeroed out by appropriations, so zero appropriations. And if we look at priced out, is that a mechanism that might offer a near-term efficient way to put the money back for appropriation and begin to address the pricing part?
I mean, it hasn't. It's still there, but after a decade of, in the Obama administration,
didn't even appoint any members, went nowhere with it, certainly not this administration. I think what you're seeing for pricing in this administration is much more like Larry was talking about earlier. Let's require disclosure of the prices, which, you know, I would say if on this topic, I think maybe a more promising approach is trying to get prices disclosed, not the level of every single component of a car, but the price of a car. Where price competition has seemed to work is when people who run benefits programs like CalPERS or Lowe's or Walmart give people good information on the all-in price that they can expect for their colonoscopy or their MRI, and let them save the money if they choose a less costly but good, with good quality measure provider. I think a lot of people think, well, you can only do that for colonoscopies and MRIs, but it actually works, as CalPERS has shown, for a lot of other elective surgeries, and now they're even doing it for cancer care. So I think you can apply to a lot of healthcare.
I would just go back. I'm thinking of the of Larry's colleague Karen Politz, and I've forgotten what the provision was called in the Affordable Care Act with the information on to compare insurance plans across procedures, which I think what is that called? Do you know it offhand? But I don't. But I think that it was implemented so gently that it has not remotely had an impact, and I think that that's got a lot to do with a reluctance on the part of insurers or providers to be transparent about their prices. But to your point, and I don't know, Christina, whether you found it yet, that whether I thought it had been repealed, the IPAB, but you think not. But I think there's always an issue, although I testified on its behalf more than once because they couldn't find anybody else who would.
Probably you're taking volunteers.
that a challenge there, and why actually the House was never very fond of it, is that it delegated to the congressional power to an executive board, and there was concern about that. And then when we changed, when the administration after 2016, I wasn't so sure that it was such a good idea to have an executive board. I think that is problematic, and unfortunately, it's meant to substitute for, or to deal with the fact that members of Congress care too much about those contributions and the providers, and to offset that. But I think it could be an enforcer for price regulation, but I do believe we need more price regulation.
There have been other delivery system reforms that were in Obamacare that have since been repealed or destroyed.
Well, but there are others
that
have had bipartisan support, like the Center for Medicare and Medicaid Innovations. So, it's something to build on.
Or bundled payments.
Bundled payments coming out of that. Yeah.
So there, which I think is too bad that basically got nipped in the bud by price. But.
Back there.
Hi, Ron Quays-Barth. Okay, so let me start off with the personal side of it. I have a not rare, but unusual cancer. And it is, well, let's just put it this way, it's one of the deadliest. So I'm dealing with this on my own, personally. I have an oncologist, she's very good. I do my own research, do a lot of alternative med stuff. But if the bottom line came, and I'm, to her astonishment, 27 months out, not needing treatment, official as of last Monday.
Congratulations.
Thank you, sincerely. So here's the thing. For what I have, it wouldn't so much, unless there was a stem cell replacement, to get into specifics, so much involved the medicine treatment side, but it would heavily involve the drug side. And the drugs have gone up astronomically. Anyone who's here familiar with Revlimid, take a look what happened to it. So here's, and I understand how the disadvantaged side of society can get in a very difficult bind. But the way it's worked out for me is that I either have to be wealthy or poor, or I am paying through my Medicare copays that 30 to 40% of the cancer patients, and for what I've got, it's probably higher, will go bankrupt. You know,
You're addressing to connect it to things we've said, that when we talked about Medicare-for-all, not recognizing that Medicare has some work to do. You're reflecting significant
I don't blame
holes in it.
Medicare so much as I blame the, and Elizabeth Rosenthal in An American Sickness got into this, as I blame the coordinated attack between both parties' politicians. Look at the contributions, go to Open Secrets and look at the contributions,
Pharmaceutical.
check it out, of
Yeah.
both
Yeah.
parties for drugs and for big medicine. And that has provided the political underpinning to keep these prices soaring. Even when, and it sounds like some of you know this, they can tweak the formulation and it starts a new patent. So observation question.
You know, I just want to say that this is another manifestation of the power of the supply side, that they can just raise prices at will or randomly. And I like Americans to know that other countries with private health insurance systems, Switzerland, take Switzerland for example, 100% private health insurance. Who decides drug prices? Who decides? Who sets drug prices? I got this out of the mouth of the Swiss health minister. I was doing an interview with him to write an article on the Swiss system. He looked at me as if he was dumbfounded. He says, I do. See? So it doesn't have to be that way, and I think it is so cruel, America, to do this.
No one protected my industry from competition. Why is American big pharma, why can't I go to some other country, ignoring these sort of suspicious ads about the quality of the drugs in the other country?
I think we have time for a couple more questions, and then we have food and drink as well. Right here.
Kevin Wu, earlier you talked about how an all-payer system could be an option, the same price within each geographic region that providers and a group of payers together agree to. So as you probably know, Maryland has done this for a while now, and they've done it with things like global budgets, and other states are thinking of doing it or are doing it. I wonder if you think there's any lessons to learn from them, and if maybe this has to go through several more states before it could be considered on a federal level.
I think the lesson is in the evidence, because 2018 was the end of the 5-year initial contract that CMS signed with Maryland to do this all-payer, but CMS extended that. They signed another 5-year contract, and they're expecting more savings the second year. So yeah, and I think that, I am thinking of maybe you can come help, how to propagate the idea.
Yeah.
Because it will help everyone.
Keep in mind it's not fully all payer yet. They started on the inpatient side, they've gone to more global budgets for hospitals, but there's a whole lot of activity on the outpatient side, and that's where you actually like to switch more of the spending, right?
Yeah.
So you need to, I think they're trying to get a bit more comprehensive there, but
See, now
it's still a work in progress.
Yeah. Now the Maryland all-payer, it now is extended to outpatient care and to nursing home care. So it's growing in scope. So we just need more states to participate.
I think it's
Judy,
useful.
it's capitation kind of.
They're regulated rates. That's okay with me. It's useful for you to think about it historically, that in the 70s there were 8 states with all payer rate settings. So you know that, and in fact the what was then the Health Insurance Association of America welcomed rate regulation on the grounds that insurance companies would manage utilization and that government could regulate prices. They shifted ground in the 90s, when the Clinton administration came in, and the nation went in a different direction in terms of competition and choice, and so I think that we ought to reconsider and move back in a direction that we saw some potential success with.
I think right now Washington and Oregon, they're considering too.
Great. Well, I think we have time for one more question, and then, yeah, over there.
Andrew McPherson, thanks for a terrific event, Kaiser Family Foundation, and for such a towering, really legendary figure in health policy. I first encountered Uwe in 2006 through another towering figure's speakerphone, Chris Jennings. And they would talk on, really, it seemed like a weekly basis, and I worked for Chris, and it was a great honor to learn from Uwe throughout the years. Uwe said that when Massachusetts passed health reform, that Massachusetts was an adult and the rest of the states were adolescents. And my question for the panel is, as we think about, we go through these sort of cyclical moments in health policy where the states innovate. And we've heard a little bit of talk about the states, but what are we seeing across the country in terms of laboratories? And Mark, you can't talk about North Carolina. What are we seeing?
Talk about other states?
What are we seeing? I'd like each of the panelists just to answer. What are some of the states that are doing the most innovative work in access, in coverage, quality, and delivery?
I think California just did something big, right? They're going to cover what's the correct term? Illegal aliens.
Undocumented.
Undocumented. Yeah. And then some states are talking about introducing the all-payer system. I think Connecticut tried to do that, but it was, again, dead on arrival because the legislature wanted to introduce it, but then Cigna cried foul, and so they pulled it off the table. So, I mean, so I think that the changes will come very incrementally, bit by bit by bit. I think that in California, Drew, you can talk about that. Governor Newsom, initially he wanted to do like in less than Medicare-for-all, but he's back on the Medicare-for-all track. I don't know. That's what I heard through the grapevine.
I would add, we talked about the public option earlier. Washington State became the first state to actually pass a public option. And it's a bit of a hybrid, maybe a public option that Mark and Judy would design together, where the state is defining the terms of the public option, but contracting with private insurers to implement it. And there are states, Mark talked about North Carolina, Montana also has been using its state employees program to try and use reference pricing to drive down prices in hospitals. So it's one of the implications of the Trump administration's flexibility they've given to states in Medicaid and in the ACA is pushing so much of this back to the states with some innovation, but I think also with red and blue states moving in some cases very different directions.
Say, not all of the innovation I think has been good. In particular, in Medicaid work requirements, which is through Medicaid waivers, for the expansion population, which has been struck down in Arkansas and Kentucky, and I don't know if the other ones have gone to court yet. I don't think so. They've been challenged. New Hampshire, right, was one of the other ones, but that hasn't gone to court yet. But that's an innovation, but arguably one that does not promote health and does not promote access to insurance or care. But beyond that, I would say that another policy change, if you want to call it an innovation, that I think is interesting that I sort of referenced earlier, has to do with how Massachusetts is treating hospital mergers, that the number 2 and number 3 hospital systems merged because they said that was the only way that they could compete with partners, the number 1. And eventually it was approved, in part because they agreed to some price regulation, which is an interesting solution, and one that I wonder if other states will start to copy going forward.
More like overall spend per person
Right,
spending.
right.
Growth.
So it's a little bit different than the price regulation we've been talking about.
Capitation.
Yeah.
The only thing I'd add to this is that there's a diversity in terms of state preferences reflecting the diversity in this country, which is, I think, not going to get settled anytime soon, unfortunately, about what the role of the federal government is, especially in guaranteeing access to, I should say, health care insurance, not health insurance.
Okay.
But where states, I think, are doing some really interesting things is around changing how they pay for care, what kind of care models they're supporting. So Massachusetts, Washington, North Carolina, Virginia, I could go on and on, taking steps that have been hard to do at the federal level because our country is so big and because of, no doubt in no small part, the lobbying things like Uwe has talked about, where you can actually get more done at the state level. And I think some of those are proving out well. Some of the most interesting things I've seen, both red and blue states, are steps to really start addressing social and community-based factors that are they're so important, the drivers of health for low-income populations, rural populations. They're responsible for those trends that I started on, where we're actually really starting to get to just close with a point about distributive justice and equity. Over the last 40 years, the biggest redistribution that's happened in terms of equity in this country has been the ACA, right? And so it was like pretty much since Great Society, and that's pretty much all on the healthcare side. What you're seeing now is, with these other steps, some more redistribution that goes to social services, housing, things like that. It hasn't nearly made up for the decline in redistribution that's happened over the last few decades in those areas as state budgets have really shifted towards
Right, you're sort of
healthcare.
mixing on redistribution, the tax cuts there.
Tax cuts are a piece of that too. You're right.
I would say
a big piece of that too. But on the spending side, you're right. It's the healthcare, and on the tax side, right, there were some tax increases, but as healthcare spending has kept going up, the employer tax exclusion is still huge for the middle class and wealthy.
And provides risk pooling in that area. I would want to add, Andrew, to the list of state innovations. It is Washington State, but we haven't mentioned long-term services and supports. And Washington State has enacted a program, and that is, Maine had failed, Washington accomplished it. And it is, I would say it's not formally part of healthcare system, and the services are in large part personal care, not medical services. But there are many people with it. You can't, I think, have an effective healthcare system without also having adequate long-term services and supports. And I would say some action at the state level is helpful in moving it up the agenda.
Yeah, I think all the things that you talked about, I would say the more the better, because if you think that the ultimate objective of a healthcare system is health, right? Now, different stuff, like Uwe would say, goes into the production of health. There are these things you're talking about. There's genetics, there's lifestyle, and then there's healthcare. And healthcare per se is only about 10% of what produces health. And so that's why I say the more the better. If we can shift our emphasis on spending, what do we spend it on?
Well, sounds like a great place to end it, which we have to do anyway. There's a reception down in the lobby. I hope everyone can join us. And please join me in thanking the terrific panel and thanking Uwe as well.
Right, absolutely.